Paul, I bought the world's worst thesaurus yesterday, a word I struggle with.
Uh-huh.
Not only is it terrible, it's terrible.
That's good. I don't like that one.
That's a smart one, Paul. I thought you might like it. All right.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and probably the primary care physician. At least that's what he's telling people. And if you could see his T-shirt, it says that on there.
My mug, my business card, all of it.
Dr. Paul Nelson Williams. Hi, Paul.
Hey, Matt. How are you?
Good. How's the ego?
It's great. I'm doing good. Thank you.
All right. Well, this is a digest episode. That means that we are joined by two friends, and we're going to go through some articles and stories in medicine. But Paul, before we do that, will you just give the audience a reminder? Who are we? What do we do?
Yeah, sure, Matt. As a reminder, we are the internal medicine podcast. We normally use expert interviews to bring you clinical pearls and practice-changing knowledge. Tonight, a little bit of a different episode. This is our digest recap. Do we have a name for these, Matt? So this isn't quite hotcakes, but we actually review stuff that was reviewed in our excellent Curbsiders digest edited by Nora Taranto. We go through some of the articles that have already been highlighted there and talk about them in even more gory detail.
And we have with us returning guest, Dr. Alex Chaitoff. Alex, thank you for coming back on the show.
Thank you guys so much for having me. This is the highlight of my semester.
Well, we're happy to have you because you have an MPH. You know about epidemiology. You know how to analyze the literature at a high level. So very happy to have you here. And then, of course, with us, the editor of the digest herself, Dr. Nora Taranto. Hi, Nora.
Hey, Matt. How are you?
I'm doing well, and full disclosure to the audience, Nora may have a respiratory infection, and we were talking about ways to avoid that when you go to the big conferences. So if anyone has any tips, send them our way.
Yeah, we've landed on like nasal gel, which I don't know. I need to look into the evidence for that. So
yeah. I heard about this yesterday, Paul. Apparently there's some nasal gel that you can use when you go on a plane or to a conference. And if something's trying to get into your nasal passage, it's like an antimicrobial gel so that it will stop you from getting an infection.
Great. Is this evidence-based or this just exists?
I don't know. I haven't looked it up. I just heard about it yesterday, but we were just, anecdotally talking about it. So maybe the audience, tweet at Paul and let him know.
Or if they'd like to sponsor us, that'd be great.
Yeah.
It sounds like any gel you can just put up your nose and then maybe that should do it.
Sure.
Yeah. All right. And before we get started, a reminder that this and most episodes are available for CME credit for all health professionals at VCU Health. Visit curbsiders.vcuhealth.org. And we're going to start off with some appetizers, if you will, in the way of our digest. And the first one up is that home test kits are now available for cervical cancer screening. We had covered, Paul, a while back, right, about this in-clinic testing. I don't know, Paul, are you doing that in your clinic yet as America's PCP? Has that reached you guys yet?
It has not as of yet.
Yeah. I expect in the next few years this will all become much more popular. I think is very patient-centered, so it's great. There is a new wand, which is teal in color. We won't say the brand name, but you can find it with that information. And this is a wand-shaped tool. It received FDA approval just recently. It has like a cotton swab at the tip of it, and it's used kind of like a tampon. They can collect the sample, they can eject the cotton swab, and the kit comes with some sort of solution that you put it in. And that is going to be available sometime soon. I try to look up prices before this. As of June 2025, at least this part of June, they did not have any prices listed yet, and they had like a join the waiting list thing on the website. So I was excited to see this because I think it's just going to increase the rates of screening. And a lot of the time when you do see cervical cancer now, it's people that were never screened or just overdue for screening. So Nora, in your world, you're in the cancer world. Is this something that you're seeing? Do you think it's going to be received favorably by oncology?
I mean, I think anything that will get more people screened is a good thing, and this does seem like it's going to significantly lower the barriers to screening. Like I think I know people just anecdotally kind of who are in medicine themselves who have trouble getting an appointment to get a pap smear and HPV testing for themselves. And so I think that this is important, and I hope will change the screening rates for cervical cancer in particular.
Yeah, absolutely. And Paul, the study that got this approved was called the self-serve study. What do you think of that?
I've tried to find out what the CERV for the home audience actually stands for, because my criteria. If this is a true acronym, this is home run, this is slam dunk, this is an incredible trial name, but I could not prove that it was actually a real acronym and not just something clever. That if they managed to make the serve part actually work, this is genius.
Yeah.
But then also from a primary care standpoint, just echo, it's the barrier is always, people often like, okay, you should come back for a separate visit for cervical cancer screening, or we'll refer you to OB-GYN, which is like waiting for that appointment. So to lower the barrier of entry like this is deeply exciting. But
yeah,
I know you're asking about the trial name, which I am ambivalent about until someone tells me what SERV stands for.
All right. And this was, if you want to read more about it, it'll be in the show notes. This was covered by Beth Garbitelli, Dr. Beth Garbitelli, in the digest number 65. And, now technically patients can either self-swab in clinic or with the at-home kit. And I'm sure we'll have more options available in the future. And hopefully cervical cancer will just be even more uncommon than it already is. Nora, next up, you have something to talk about. So who covered this and what are we talking about?
Yeah, so this is our next little app, which I think is probably worth a mention. This was covered by Dr. Alyssa Mancini in digest number 65. And this was study Essence, another nice name, I would say, which was a phase 3 randomized placebo-controlled trial of patients with biopsy-proven metabolic dysfunction-associated steatohepatitis, or MASH, and moderate or advanced liver fibrosis. So that's stage 2 or 3. And these patients were randomized to either once-weekly semaglutide or placebo for 240 weeks. And this was actually an interim analysis, but it showed resolution of steatohepatitis without worsening fibrosis, more with semaglutide than with placebo. And then they also saw reduction in liver fibrosis, more with semaglutide than with placebo. There was increased weight loss as well in the patients who received semaglutide compared to placebo. And so I think this is just adding to our literature suggesting that semaglutide is really helpful treating many different metabolically driven diseases. I'm curious what you guys are thinking about it.
Alex, any specific thoughts?
I'm just waiting for the study that shows it's unhelpful.
Yeah.
Well, that'll be
Yep.
need its dedicated episode.
I'm calling this the antidote to the American lifestyle. That's what I think this drug just kind of cancels out the normal American lifestyle, and then people get healthy again. But Paul, what do you think?
I am kind of impressed with placebo in this study. I'm not going to lie. I will say that a 22.4% reduction in fibrosis for people with placebo. It's like, if you told me a medication did that, I'd be like, not bad. So the fact that semaglutide is better than that, like, impressive, and I guess not surprising. Yeah, I'm with the real. Like, it seems so beneficial cardiometabolically in general that this is not really a surprising result necessarily.
Yeah.
Yeah, I think what will be interesting potentially and a little different is the progression to cirrhosis, which they haven't reported on yet, and I think is the next phase of this study, kind of for those patients who are later stage, whether this actually changes that specific outcome, which obviously leads to substantial other poor outcomes.
That's a great point, because the surrogate endpoints, like, we should you want the hard clinical endpoint, and cirrhosis is I guess with the liver, other than death, cirrhosis is like the hardest of hard endpoints. So it'd be good to know that for sure. And I don't know how to pronounce this other drug name, but resmetirom it's the liver specific drug. It's approved for, steatohepatitis, and it actually works without weight loss. So I think it's not really. I tried to look around for it, and in the paper they don't really know. Like I think it's just weight loss and just the fact that the person's getting metabolically more healthy as to why the drug works for MASH, but they didn't say specifically. But I think if there was no weight loss, then it wouldn't do much, is my guess. But we don't know for sure. But it's neat that other drug works in the absence of weight loss.
Yeah, and I think the earlier phase study of semaglutide also suggested that it was tied to weight loss in some meaningful way. So that's probably right.
Well, Paul, we are moving on to some entrees. And first up, Paul, you're serving up something.
So that smooth transition, Matt. That's why you're a pro. So we're talking about the New England Journal of Medicine article, Male Partner Treatment to Prevent Recurrence of Bacterial Vaginosis by... apologies in advance. Vastrasil et al. For the Step Up team. So this came out in March, so a recent thing, and it's exciting to me because we see lots of bacterial vaginosis in primary care, and then just even hearing statistics, I was kind of floored by affects a third of reproductive aged women with a high rate of recurrence. In the article itself, it cites I think upwards of 50% of patients will have recurrence within 3 months. So like it is, and like we encounter this all the time in clinical practice as well. And there has been this longstanding thought, like, well, what if we try treating male partners if they are harboring the cause of bacteria? Could that, in fact, reduce the risk of recurrence? And there have been prior studies looking mostly, I think almost exclusively, at oral therapy to reduce the rates of recurrence in their female partners. And those studies have been mixed to negative for the most part. There are, I think, Cochrane meta-analyses and other things that show that treatment of male partners in women with BV does not lower the rates of recurrence. This study, a little bit different. It's an open-label randomized trial. So they recruited male partners of women diagnosed with BV and randomized them to either oral and topical antimicrobial treatment or the standard of care. And in this case, the standard of care for the male partner is nothing, and just sort of watching to see what happens. And so the way they recruited Matt is they actually screened premenopausal women who presented to a sexual health clinic. If they had symptoms, they met diagnostic criteria for BV by either the Amstel criteria or this Nugent score, which is this microscopy score of 4 to 10. Then the women were considered eligible, and they sort of proceeded to enrollment. And these women were then asked for their male partners, and if they could enroll the men within a week of the patient, the female being seen, then they would actually enroll the couple, and the trial proceeded from there. The inclusion criteria are probably important here. Everyone was over 18 years of age. They understood English. They were not to have other sexual partners at the time of enrollment. They could not be sex workers. They could not be known to be living with HIV. And then these couples were randomized to the partner treatment or a control group. And the treatment, just to be very specific, was either for the male partner was metronidazole 400 milligrams twice daily plus topical clindamycin 2% applied to the glans penis twice daily for 7 days. And this was an open label trial. So the study participants knew what they were getting into as soon as they started getting with the treatment. So I'll pause there and see if there are any thoughts before I continue to roll through it and let you know what they actually found.
Paul, so this I didn't realize this was so controversial until I was reading about this, or not that super controversial, but that bacterial vaginosis is it considered a sexually transmitted infection now, or do you think we should after going through this? You know, that was one of the main things, because like there's not really a test for men. I guess there is, but not that's like widely available for us to use. I guess in research they can test men, but they did not test the men in this. They just empirically treated, right?
That's correct. Yeah, exactly right.
Yeah.
So it's been, I'd love to hear what other people think about this. Like BV has typically been categorized as a dysbiosis, which I think is a little bit different than an STI. So it's sort of an imbalance in the flora. I think if we believe the results of this study, that would be framework shifting. I think this would then putatively show that it was actually transmitted from the men, and as a result, that would, I think by definition would then classify it as an STI. But I am no ID expert. You might be shocked to hear. I would love to know if that changes anyone else's thinking about the disease.
Alex, any comments on this?
No, so far I have no additional insights to add to whether it is sexually transmitted or not. I had also thought of it as kind of a dysbiosis, but I think the thing that jumps out to me here, and I know it is this, and then we'll bring it up a few times, is this open label piece that we heard about so far, is what jumps out to me, especially because of some of the outcomes that are chosen in the trial that certainly can potentially be impacted by that.
And just to end that point on the editorialists, Doctors Musney and Sobel in the New England Journal editorial, they did say the major paradigm shift that this trial represents will require clinicians to educate their patients on the role of sexual transmission of bacterial vaginosis-associated bacteria. So, I mean, it seems to me like they're buying that maybe this is, sexually transmitted now. All right, Paul. So what statistically or, anything you wanted to point out, Paul, as far as important, results or limitations, et cetera?
To be explicit, the primary outcome, in case it's not apparent, is that recurrence vaginosis defined by these Amstel criteria and Nugent scores. So they actually did questionnaires and collected vaginal samples at weeks 4, 8, and 12 in a combination of in-office and then also at-home testing. And at 12 weeks, the recurrence of BV was observed in 35% of the partner treatment group, which sounds not too terrific, but then you compare that to 63% of the control group, it becomes pretty meaningful. So this corresponds to an absolute risk difference of 2.6 recurrences per person year, which is a absurdly low p-value. And they actually, so significant, in fact, that they actually stopped the trial early at interim analysis because of the inferiority of the control arm of treatment. And so things that you think about with this is, how was adherence? And not terrific. 14% of men in the treatment group said that they took less than 70% of the prescribed medication, yet we still had this significant treatment effect. And there weren't really serious adverse events. There were reports of skin irritation, not surprisingly, for people who received the topical treatment. So per this study at least, it significantly reduced the recurrence of bacterial vaginosis when treated with both systemic and topical therapy, which is different than lots of studies that have come before this. And it was different in part because of the actual topical treatment putatively sort of wiping out Florida that are known to actually possibly transmit, possibly is not really a meaningful sentence, but that are known to transmit BV to female partners. So I don't know. I think it's an impressive study. I think it's and somewhat hard to argue, though I will say that it is sitting at the forefront of a lot of other studies that have had negative results previously. So you have to, I think, take it in that context. I would love to hear other thoughts, and if this will be practice changing for you all before I sort of weigh in with my final rating.
Yeah, let's go to Alex first.
I think other than, I didn't see it. Maybe Paul, you could fill me in if there was a reason they do these open label. Is there an ethical reason or something to not just get the gold standard and take away that little bit of doubt?
They do mention they did not use placebo ointment out of concern for actually changing the local flora. They feel like that would sort of muddy the waters, which I thought was an interesting justification for not doing that. So that was the reason that was laid out in the paper, at least.
Okay. I think aside from that, I think I think it's pretty compelling. I think that it's something that I will say, would want to see written into guidelines maybe before I change my practice, just because I do worry about things like microbial resistance. And this is not a purely an area where, issue had never been studied. Now we've studied it for the first time, and it's overwhelmingly moving our priors or from nothing to something. There are those negative trials. People have been getting systemic therapy, as you kind of mentioned, some of these previous trials that did not show much of an effect. And I don't know that I would feel comfortable without some experts weighing in guidelines that the risk of antimicrobial resistance rates or overtreatment potentially is not minimal, and we shouldn't be treating partners.
I'm also kind of on the partner piece of this. I do think it's maybe a relatively important limitation to think about, that the partners were male partners only, not female partners, and kind of how this actually can be extended to female relationships, and whether or not this data kind of aligns in both populations is unclear. I don't see any reason it wouldn't be, but I think maybe I don't know whether the topical and oral is needed in that situation, nor do I know whether, and we were talking about this a little bit before, I think none of the other prior studies have actually studied that population with just oral systemic therapy. So I think it's probably a limitation to interpretation here.
Yeah, I think that's great. And I agree with all that. I think the other thing that is worth raising is that the patients studied in this group actually had a pretty high risk for recurrence because of other risk factors as well. So 80% of the men in this study were uncircumcised, which is different than sort of the American population, and there is an association with being uncircumcised and having an uncircumcised partner and incidence of bacterial vaginosis. And then there's also a fairly high rate of IUD use in this population, which also is a risk factor. So these are folks that had sort of a higher risk for recurrence kind of at their baseline. So I wonder if that will impact guidelines going forward, if this would be the type of treatment for sort of higher risk patients for recurrence, or if that will factor in at all. So I think there's sort of other nuances that will need to be teased out before this is ready fully for prime time, but still I think an exciting study.
Yeah, I think probably the way that I would handle this, Paul, is if you have somebody that's on their, second or third recurrence of this, the first time someone comes to me with bacterial vaginosis, I might not recommend partner treatment. But if they're having multiple episodes, then I would probably treat partners in that case.
Which comes up all the time. Yeah, I think that's exactly right. And you see even patients with monogamous partners or have just one single sexual partner who have multiple episodes of recurrence. And you're just like, what are we doing here? And then you're sort of down the boric acid suppository rabbit hole, which is just sort of unpleasant for everyone. Like this might be a nice alternate option that might actually reduce the risk.
It would definitely be worth, as Alex was saying, like kind of validating this with another follow-up trial to make sure this wasn't just like a one-off, because of the open label that made it look better.
Also, especially since I think I remember this, but I think there was crossover that was allowed where patients in the control arm were allowed to get treated. Their partners were allowed to get treated if they had a recurrence.
That's right.
And so that I think could potentially significantly bias the results in an open label design like this. So,
all right. Well, we are going to move on because we have a couple more articles to talk about. And the next one is this statin plus ezetimibe therapy. This was covered by Josh Gilman in Digest number 65. And this was by Cha et al. The title of the study was Safety and Efficacy of Moderate Intensity Statin with Ezetimibe in Elderly Patients with Atherosclerotic Cardiovascular Disease. This appeared in the Journal of Internal Medicine in 2025. And this was another positive trial. They were mainly looking here for statin-associated muscle symptoms. So if someone has known ASCVD, they should be on a high-intensity statin, but especially in older adults, you worry about statin-associated muscle symptoms, or SAMS as they abbreviate it in the trial name. This was the SAVE SAMS trial, Paul. Pretty good, right?
Yeah, it's not bad.
I mean, it meets your criteria, but it's not the coolest word. But
it also doesn't mean anything. So like it's So it's they went in the wrong too hard in the opposite direction, unfortunately.
I have to say, I always get tripped up when like the outcome is a incidence of a positive acronym. And I feel like for some reason it ends up confusing me.
So let me explain to the audience how this was a positive trial. This was, the combination group experienced a lower incidence of SAMS, so statin-associated muscle symptoms, compared to the high-intensity statin group. So there was about 0.7% in the combination group versus 5.7% in the high-intensity statin group. So 5% absolute difference, which was significant. And then the secondary outcome of LDL cholesterol lowering, the LDL cholesterol lowering was about the same in both groups. And actually the total cholesterol lowering also about the same in both groups. And there was a lower incidence of new onset diabetes in the combination group. So the higher intensity statin was more likely to cause someone to have a new diagnosis of diabetes. So this also was an open label design. And so I would like to open it for comments, questions, concerns. Alex, we'll start with you again.
Just hating on open labels today. I woke up on that side of the bed. Yeah, I think that in this study, the open label piece is probably significantly more likely to come into play than in the last study we just talked about, where there were objectively some, at least at the end of the day, there were some objective components to the measurement, gram stains and such, whereas this really is, driven by symptoms in some ways. And we know there's a big nocebo with statins, and it's one of the most widely recognized symptoms people know about that are associated with a medication happen to be those myopathies. So I think that that's potentially problematic. And the other thing that just jumped out at me is I was kind of reflecting and saying, okay, if I had a patient who had ASCVD and I was thinking of a medication, would I ever start them on a low dose statin and ezetimibe, or would I really be trying to get them on a high intensity statin, and then if they couldn't tolerate it, choose something else? And so I wondered whether this was picking the trial population I would have potentially targeted, which would have been people who couldn't have tolerated a statin to begin with, or people who couldn't have used a PCSK9. They had no other option, then go down on the statin or go off of it and try ezetimibe. And this could have shown, hey, look, they could just go down on the statin. So I wondered whether it was the perfect population that I would have picked to study this, at least as we practice in the U.S.
Mm-hmm. Yeah, this study was done in Korea. It was in South Korea, not directly as applicable here, but yeah, the open label design. I mean, you certainly could imagine how if people are reporting statin associated muscle symptoms. I mean, they said whatever researcher had to call these people and administer the survey was blinded to what group they were in, but the people certainly knew. So I don't really see how it helps that much that the assessor was blinded. But yeah, I mean, it's reassuring that they didn't have more muscle symptoms in the combination group and that the cholesterol lowering was similar, but we don't have a hard cardiovascular outpoint here to say that like they did just as well clinically as the group from a cardiovascular standpoint. So that to me is a limitation. But I think that, well, actually, before I give my final, Nora, I want to hear from you, and we'll go around the horn and go to Paul next too.
Yeah, I mean, I think everything that both of you have said, I agree with. It's hard to know what to do exactly with this, and I think you were about to say this or may have mentioned it, but the follow-up is pretty short here, and so like understanding long-term outcomes for this population is tough. And I think they were probably getting at this kind of higher risk of myalgia cohort with the elderly patients, I think over 70 here, but you also run into issues with polypharmacy for that patient population. And so like adding 2 medications, is that necessarily better for all patients who are over a certain age? Probably not. So it is hard to figure out who exactly is most likely to benefit from this.
Paul?
Yeah, it's tricky. It's a patient group that I'm interested in. It is a problem that I have that comes up. I feel like these days I'm seeing less and less sort of reports of statin associated muscle stuff. In part, I don't ask about it, and I also don't do a whole lot of pre-counseling just because I don't want to plant that seed, which maybe makes me a terrible doctor. But having said all that, like I agree with Alex that they kind of got to the questions that I have in a way that seems sort of indirect and could have been asked in a different way that would have been perhaps a little bit more rigorous. And it's just sort of, it's, I guess, reassuring that I can do this if I need to for someone who has myalgias and needs significant cardiovascular risk reduction, but there are also PCSK9, so if they don't want to do that. So again, reassuring, not really practice changing so much for me. And I think there's probably better ways to have answered the questions that I have, which is maybe not the same questions that they were asking.
Yeah, so if I have a patient who is not tolerating a statin or just not a goal on a statin, sometimes I will add ezetimibe. The combination pills available in the U.S., I mean, the rosuvastatin and ezetimibe is available, but it seems to be more expensive. The simvastatin and ezetimibe is on some formularies, but not as potent of a statin. So. And a lot of my patients, like you all were saying, don't want to, like if they're already taking a statin, they don't want me to add another separate pill. Like most patients, if I put them on a combo pill, they feel like it's still one medicine and they're fine with it.
Yeah.
So maybe if the combinations become more available, I'd be more likely to use it. But I would really like to see harder endpoints for this before I would really, if it's someone that's just on a statin and they're wanting to get their LDL to a better goal, I would be more likely to go this route. But if it's somebody that had like a major cardiac event, I would probably try for the PCSK9 inhibitor if they couldn't tolerate a statin and if we couldn't really get their LDL to where we wanted it to be.
Yeah, I mean, the practical concern, the PCSK9s are still injectable, so which is a barrier for some folks. So, like,
Yep.
I would see myself getting to this treatment endpoint by walking backwards from like, okay, too high a potency statin, so let's dose reduce now the ezetimibe, and not in the way that this was done. Yeah.
Yeah.
Yeah, and
All
I,
right.
I think I guess the only other thing I was going to say, I think Alex, you mentioned this before, but what you would really want here is patients who are not who wouldn't tolerate a like statin dose reduction, who wouldn't tolerate the higher dose to begin with, and then if you tried to switch them to a lower dose with ezetimibe, they would either say no or they wouldn't want to do that. And so that's kind of the patient population I wish or am hopeful that this study is looking at, but I don't know that it is.
I also just, as we asked, like, was this asking the right question with the right people, with whatever? There are also other studies that have shown, like, if the question is simply, does it work for LDL reduction, that we kind of know. And there are a few other studies actually out of South Korea that have also shown the ability to lower double-blind studies actually that have shown the ability to lower cholesterol similarly between a ezetimibe and a lower dose of rosuvastatin and rosuvastatin alone. So it's also one of those where I don't know that even the top line result, and in those studies they have, they do look at adverse events. Even the top line result I think is not as novel as even throwing aside the open label piece and all the other stuff.
Right. Yeah. All right. So if we were doing hotcakes ratings here, Paul, this would be like a 3, I guess. It's the headline's better than the actual paper, maybe even a 2.5. That's like middle of the road, right?
Oof.
It's out of 5. So
I'd probably go 3.
okay.
What am I doing with half a hotcake?
All right. Moving on. Nora, you have an article to talk about, and this is very much in your world, the world of oncology. So what do you got?
I have the challenge trial, Paul.
Again, it depends. What does challenge stand for, Nora? No,
my
looking
gosh.
at it here, colon health and lifelong exercise change. Boo to oncology.
I know. Okay. Well,
Focus on saving lives.
yes, they can improve upon this one next time. But this is a study that just was published in the New England Journal by Cornea et al. And was the talk of ASCO this last 10 days ago. And this study looked at exercise and the risk of cancer recurrence, specifically in colorectal cancer, and actually overall survival. This is a randomized clinical trial, and it is trying to address a question of great interest that has been the source of many, many different observational studies focus. And this is whether or not exercise can decrease your risk of cancer in various ways. We know exercise is good for you in many other fields, and there are a number of preclinical studies that have linked different mechanisms to increased exercise and suppression of pathways that facilitate metastasis and immune activation, as well as activation of tumor suppressors. But all of the studies thus far that have looked at the link between exercise and cancer risk have been observational, in part because it's a really hard thing to design a randomized study of exercise without any industry funding such a study in oncology. So that's one really impressive feat that these authors actually were able to manage to conduct a randomized trial of exercise in oncology. The study challenge was a randomized phase 3 study comparing a 3-year structured exercise program plus health education materials provided to health education materials alone. This was in patients who had early stage but higher risk colorectal cancer. And so these were patients who had either high risk stage 2 or stage 3 colon cancer. They had to have gone through surgery, complete resection, adequate resection, and then also had to have finished adjuvant chemotherapy within the prior 2 to 6 months. And if they were eligible on those bases, if they had an ECOG performance status of 0 or 1, and were able to exercise in kind of moderate to vigorous ways, they were randomized to either the structured exercise program for 3 years or to these health education materials.
Let's get to the top line results, then we can dig into the rest of this. So what are the top line findings and what were the headlines about this one?
So yeah, this study got a lot of headline activity over the last 10 days. You may have even seen it. The primary endpoint was disease-free survival, and one of the primary secondary endpoints was overall survival. And they did see a benefit in disease-free survival in these patients with exercise. So you had improved disease-free survival if you exercised on this structured exercise program compared to if you were randomized to the health education materials alone arm. And they also saw a significant improvement in overall survival with the exercise arm compared to the health education materials arm. So this obviously got a lot of attention in the news and at ASCO, and people have been trying to understand, is this really coming from the exercise? Is this coming from something else? Were these patients randomized to one arm different than the patients randomized to the other?
Yeah, so this first hit my radar because there's a Substack that I think I might have sent you, Nora, and I know I sent to Paul, this Sensible Medicine Substack. It's John Mandrola and Adam Sifu, and it used to be Vinay Prasad there as well. He left to do whatever he's doing at CDC or FDA, I can't remember which. But John Mandrola wrote an article about this, saying how he's very skeptical about this because of just many reasons. One of the things he pointed out was that the effect size of this on I don't remember if it was disease-free mortality or survival, but it was like similar to that of some chemo agents. So could you talk a little bit about that? Like how big the effects, if we believe this trial, how big the effect size is?
Yeah, I mean, they report pretty substantial absolute benefits for both disease-free survival and overall survival. And disease-free survival, just as a reminder, is an event that happens that is either, so it's time from randomization in the study to the first recurrence of the cancer that you had, a new cancer of the same type, a second primary cancer, so like a breast cancer for these patients, or death from any cause. Both of those had significant benefits with exercise, or seem to have significant benefits with exercise, an absolute benefit for disease-free survival of around 7%. And then for overall survival, an absolute benefit of around 7% also. And so they actually, in the discussion for this at ASCO, they kind of put this into context, that overall survival benefit, which is kind of in oncology trials what we're going for in all trials that are looking at survival as an outcome. That's what we want. We want improved overall survival. And looking at kind of this adjuvant exercise, you saw this absolute gain of 7% at 8 years in colon cancer. And that compares to, for example, 5% absolute overall survival benefit in breast cancer with trastuzumab, which was kind of a game-changing chemotherapy agent. And so this is a significant effect size. And so that's one reason to think really critically about kind of whether this effect size is really because of the exercise, or is there something else at play?
Yeah. So there was apparently a 50-page protocol about the exercise intervention. So it sounds like it was pretty intense and labor-intensive to administer. So questions about how easily you could replicate this in real-world practice. But Alex, for you as someone who's good at appraising articles, like, were there red flags in this one or things that you thought might have kind of biased the study towards the result that we got?
I thought that what was most telling, I will say I was impressed that they undertook it. I think trying to study things like exercise is really, really hard. And looking at the overall survival, for example, and even the disease-free survival, like curves start to separate on these survival curves when you might expect. It's not like you see one group was definitely sicker to begin with than another group. When we want to say, oh, could the exercise group have been different? Maybe, but certainly their baseline characteristics seem really similar. But what jumps out at me were two things. One is it's really it took a really long time to recruit these patients, to the point where I actually wonder if not that it would have necessarily mattered, but if treatments had actually even potentially changed over the course of this time. It took a really long time, and that leads to this second point, which is really, it's tough to know what to do with it. I think back to the diabetes prevention program. I got to bring my primary care here. Diabetes prevention programs were shown effective, prevent diabetes. Usually, there's thousands of locations around the country that one can participate, and yet fewer than about 3% of patients partake in these much less intensive kind of programs. And it just made me think, if you couldn't recruit somebody for a trial, what are the chances you're going to be able to get it out to the people?
Yeah, I think those are very, very good points. And to your question about treatment changes over the last 15 years, which is how long it took to accrue the study, it was like 2009 to 2023, I think, end of 2023. There was kind of one change, not a ton, and the arms were pretty balanced regarding the treatment changes, but I think it's a very fair point, and there is a category of kind of other treatments that we don't know as much about. But I think the second point about like how difficult it is to implement this is really astute, and I think probably the biggest limitation here. Adherence was low even in this study, kind of by year 1, and then year 2 and year 3, it was lower and lower. And there weren't significant changes to kind of other physiologic measures in the exercise cohort either. And so it just raises the question of like what exactly was happening to these patients, and whether or not they may have been more active, but like what was it the program that was actually getting them more active?
Right. I went running, screaming to the discussion for the conversation about the biologic plausibility, and there's a lot of hand-wavy insulin sensitivity, but in the absence of those other sort of meaningful, like in the absence of weight loss or sort of other parameters that suggest that the exercise is having a physiological impact, it's really hard to figure out. Like it's really hard to reconcile the treatment effect with the treatment. so it's interesting.
Yeah, and even in the like 50 pages of describing the structured exercise program, the details of how patients got facility access, it seems like it was somewhat variable and dependent on the institution they were at, and so it's just it does feel a little bit hard to know how exactly to implement this, even though I think at the end of the day, it's a good thing to recommend patients exercise more.
Yeah, absolutely. We were talking about before we went on air. I was like, how could this, this headline, getting more people to exercise that have cancer, how could that be bad? I guess if people thought, oh, it's as good for mortality as a chemotherapy, and they'll say, oh, then I don't need chemotherapy. I'm just going to. My answer would be no. You should do both, and then your survival. Hopefully, they will be additive, and your survival will be even better. But that's the only harm I could see in this. But I'm not as confident in the results. I mean, I think people should check out this Substack, what John Mandrola wrote, because it's very well thought out and in depth. And then one last thing, our own Dr. Rahul Ganatra, on our internal Slack channel had written to us about how reverse causality could explain some of the effects. So are people with less severe disease better able to do exercise? That is, do the disease characteristics influence adherence to the exercise program, or does exercise cause less severe disease? I guess we just don't know based on, we can't tell from these results. So
even if the treatment effect is a fraction of sort of what's reported here as we continue to study, it's not hard to envision a world like you see with pulmonary rehab or cardiac rehab, where you actually have like colorectal cancer rehab, like there's structured exercise in that way. It's actually part of your ongoing oncologic care, not a recommendation, but actually sort of part of the larger infrastructure to manage motor survivorship in the outpatient setting.
Yeah, I think kind of two things. One, it was interesting at the ASCO discussion of this, a number of the surgeons were saying, I want to see this extended to like prehab, which so before surgery for these patients, because there is often some time. And so I think it's actually a really interesting point for these patients who are undergoing pretty intensive and invasive procedures and chemotherapy. Like, how can we best both prepare them to do well with that, have them do well with that during actual treatment, and then afterwards be ready to get back to their normal and or kind of higher fitness level. So I
That's
could see
great.
that extension actually being meaningful.
We have one more article to get to, an unpronounceable drug, but I will try cytisinicline for smoking cessation. And this was covered by Dr. Laura Glick in Digest number 65. Alex, take us through this.
All right. I will also probably get it. You have to say it a few times to get it to really roll off the tongue. Cytisinicline. You've heard of varenicline. Welcome to a medication that has a similar mechanism of action. That is the first new smoking cessation drug potentially on the block in about 20 years. So this is actually not the first study. If you're sitting there saying, wait a minute, I remember that article in JAMA from 2023, you're not making it up. There was a study of this medication in JAMA published in 2023. It worked, but the authors, as rigorous as they are, wanted more evidence. And so they conducted a second randomized clinical trial at 20 sites in 15 states where they gave patients this cytisinicline in two different ways. Either it's always 3 milligrams 3 times a day. That's one thing I do want to point out specifically is this is a 3 times a day medication. They gave it to them for either 6 weeks, 12 weeks, or they gave them placebo. And then they followed them and they asked how many people were able to be abstinent from smoking over the course of a few weeks, 12 weeks, and up to 24 weeks ultimately. So that's the outline of the study. And I'll just let you know the folks who were included could not be using any other smoking cessation aids or treatments. So no nicotine replacement, no bupropion, obviously no varenicline. They also had to be relatively healthy, no myocardial infarctions recently. And notably, they had to be at the place where they wanted to quit smoking. This was not before you thought this is something I want to do. These are folks who had wanted to get off of cigarettes. So I kind of told you I've spoiled the result potentially by saying it may be the first new kid on the block in 20 years. But they enrolled about 800 or so, about 792 participants. And what they ultimately found is that there was almost a threefold increase in abstinence at 6 weeks of treatment. At 12 weeks, it was fourfold increase, or an odds ratio of 4, that you were more likely to be abstinent from smoking at that 12-week mark. And then even at 24 weeks, you were significantly more likely, if you got this cytisinicline, regardless of whether you got it for 6 weeks or 12 weeks, you were more likely to be abstinent from smoking at that 24-week period. And the medications were relatively well tolerated.
Yeah, it's interesting they did this 6 or 12-week treatment. And when we did our smoking cessation episode, we talked about, Paul, remember the endless varenicline? I'm not sure do you ever prescribe that for people, the more than 12 weeks of varenicline?
Not with intention, but certainly I'll continue it if it's working well for someone, but they don't feel ready to sort of fly without it, for sure.
Yeah, because that was one of the commentaries I saw on this is that, are we gonna study this medication beyond 12 weeks, because you do lose people, you do lose some of the people that were abstinent at 12 weeks by 24 weeks when they stopped the drug, which I guess makes sense.
It is interesting though, because as you said, the abstinence rate kind of jumps from the 6 week therapy arm to the 12-week therapy arm. And so suggests that there is kind of this additive benefit longer term, which if so is great.
Yeah, the abstinence rates in all these smoking cessation trials with the medications, it's always 30%, less than 30% for the most part. It's just, the numbers are very grim, I have to say. It's just...
Yep.
It makes the bacterial vaginosis response rate seem just absolutely astronomical.
Yeah. So what do you think about this? Are you confident this medication works? And how do you think, do you think this adds much? Give us your honest opinion about this.
Yeah, I think, first and foremost, I think this medicine works. They've got multiple trials. They've picked their populations well. And for a patient who says, I want to get off of these, this medicine works. I have kind of two questions. And one is, should we have a comparator group here? Like, do we need this medicine versus varenicline when we have a medicine that works via a very similar mechanism of action and is generic, not affordable, but generic? And, for example, when we were talking about liver disease earlier, it makes sense to have two medications that are completely different in mechanism of action and to have both of them available. But do you really need a second agent like varenicline that performs pretty similarly and is similarly tolerated? I don't know, but what I would have been really interested to see was this medication against something like bupropion, or even against varenicline in a blinded study. It has been studied in open label studies, but in a blinded study to try to really give clinicians something to say, oh, this should 100% be my first line choice. So that was my biggest kind of concern,
Yeah.
or as far as when I try to put it into context and trying to figure out, is this I think it's going to be helpful, and I think it's going to be used if it can make it to market, but is it going to be a game changer? That I'm just not sure.
The other thing I looked into this, like, with varenicline, the abnormal dreams are one thing that a lot of patients have heard about and scares them off. And then insomnia, those are some of the common side effects listed with that agent. And they were also seen with this agent at about the same rate, maybe like a couple percentage points less, but not super significant. It was both like a little over 10% experienced those kind of symptoms, and it was more than placebo. So I think it's, you still have to tell people that those side effects are still there. I know, Paul, I think you covered this maybe on a Hotcakes or Digest episode in the past. And there's something about this being plant-based or more natural. I think that's kind of part of its marketing.
We covered this in September 11th, 2023, when we also covered, by the way, kiwis for constipation for perhaps the 3,000th time.
One of my
favorite studies.
Apparently they work. But yeah, no, so I think part of the conversation we had back then is maybe the fact that this is more quote unquote natural might be more appealing to patients. I will say the dosing is more burdensome than the other medications for tobacco cessation. So this is based on the pharmacokinetics. They opted for thrice daily dosing, which is still one more time per day than either bupropion or varenicline. So that's another potential downside to it.
I think the previous dosing was like, I don't know where it comes from, they said, but it was
like six, right? Yeah.
Yeah.
So, maybe I guess it's an improvement on that. This is like the acamprosate of smoking cessation. Acamprosate for alcohol cessation is 3 times a day. This is for smoking cessation is 3 times a day. So yeah, I think that's rough. They'll probably make like a extended release formulation that costs $1 bajillion, but I don't know. So Alex, I was trying to read about this, and it's known for being cheap in European countries. But what do you think? You think they're gonna make their money off of this one? I guess they're studying it. They're running trials. So you think it'll definitely be more expensive here than it is in Europe, I'm sure. But
yeah, I mean, there's a lot of drugs that are nice and cheap in Europe. I think, and I apologize, as you're all talking and pronouncing these medications correctly, I realize that I'm not cut out to say these two medications properly. But I think that the question I have, and I did actually try to do some searching to see, so this study was paid for by a late stage pharmaceutical company that is putting the drug on the market, which is not uncommon. They had a couple of authors, I believe, on the paper, but do say that they gave full control of writing to the study team. And I actually tried to look through their filings and see if they had put a price point of where they thought this drug would land. And in my quick searching, I couldn't find anything. Maybe this is a use for some LLM deep searches at some point. But I will say it is odd to me why varenicline is still so expensive. Looking at Medicare data, we're talking many people paying hundreds of dollars for, per month for a course, essentially many hundreds of dollars, and it's generic. So it's, I don't think it's going to be cheap. I don't know why people would go through the effort of doing multiple trials and longer term follow-up to be, really affordable. But at the same time, it's not like there's this great alternative. Even the one that works by the same mechanism is not affordable. So maybe they'll be able to come in and it actually won't be some huge price hike. But I don't think we're going to see European prices. I would be surprised.
I put it into Perplexity. I pasted it in the bottom of the thing here if you want to look at it. This is the table it came out with. I asked, what is the expected cost if approved in the USA to treat smoking cessation? And I said, and compare it to the other agents. And it came out with maybe $100 to $200 per course compared to varenicline, which is $400 to $500 per course. But I don't know. But in any case, it's still like 5 to 10 times as much as it costs in Europe. So it's still going to be more expensive here, I'm sure. All right, Paul, any final thoughts on this one or?
Oh, so many. Yeah, I don't know. Like, I think it's good to have something in our armamentarium. I will say varenicline right now is the best we got for tobacco cessation, and it is completely underoffered. Maybe some of that's for pricing, but I think some of that's just because, I don't know, maybe nicotine patches had great marketing at some point, but we always go nicotine replacement therapy first. So I think hopefully having some new kid on the block, name recognition, something, maybe people will be offered a little bit more efficacious therapy for tobacco cessation. I will also say that people are smoking less. Like, so I think the next frontier will be to see how is this for folks who are vaping, because I feel like that is an understudied and harder thing to treat. So I think probably where the big ticket stuff will be in terms of future research for stuff like this is how effective will these more novel medications or these different medications be for vaping cessation, which is becoming sort of the new issue that we have to contend with as tobacco becomes increasingly less cool and less popular.
Absolutely. All right, Alex, any final thoughts on this one?
No, I think it's all. I think I agree with everything everyone said.
Yeah. All right. So we just need to learn how to pronounce Cytisinicline, Paul. That's it.
And just real quick, because I don't want to dissuade people from prescribing varenicline, I will say on one of those pharmacy discount coupon sites, I will not name by name, looking at like anywhere between $35 and $45 for a month's worth of varenicline. So not cheap, but not hopefully not breaking the bank for someone who's only going to do it for like 3 or 4 months.
I guess if you're going to do it for 3 or 4 months and then you're going to save the cost of cigarettes, maybe that might even out. So it's probably
we're up to $12 a pack now for most. And if you're a pack-a-day smoker, I promise you the varenicline is going to be cheaper.
Yeah. All right, there you go. Well, Paul, guess what? That's been an episode.
Chicken butt.
Should we do an outro?
Sure. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
That is the perfect energy. Are you still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/curbsiders. You can find our show notes at thecurbsiders.com. And while you're there, why don't you sign on up for our mailing list to get our weekly show notes in your inbox? This includes the Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge, and we want your feedback, so email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. I wanted to give a special thanks to our writers and producers for this episode, Dr. Alex Chaitoff, Dr. Nora Taranto. Our technical production is done by the team at Podpace. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Chris the Chu Manchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
I've been Dr. Nora Taranto.
I'm Dr. Alex Chaitoff.
That was not nearly as disastrous as I was hoping it was going to be. And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.